Hi, welcome back to part 3 of chapter 23, respiratory system. So now that we are done discussing about the pulmonary ventilations and the pressures and volumes involved, now we need to talk about the actual diffusion of gases or the gas exchange that has to occur between the alveoli and the blood in lung capillaries. And before that, we have to talk about a few more gas laws. The air we breathe in is actually a mixture of different gases. For example, nitrogen is actually the most abundant, making up 78.6% of the Earth's atmosphere. Oxygen is about 20.9%, water molecule is 0.5, and carbon dioxide is 0.04%. Again, these percentages are just for you to kind of get an idea of the gases that's in the atmosphere. Please do not try to memorize them. I will not ask for that. It's just to give you an idea. So Dalton's law says that each gas will contribute to a total pressure in proportion to its relative abundance based on collision of molecules, okay? Because we talked about how the pressure of gas is due to the fact that they're bouncing around and colliding into each other, and that's what gives them a value of pressure. So this Dalton's law pretty much means that the partial pressure value of each type of gases will contribute in a portion of the total pressure. For example, our atmospheric pressure of 760 millicurie is the total pressure, and each of these little gases that we talked about will contribute in a way as a partial pressure value. So that's pretty much what Dalton's law is doing or saying. It's really defining what partial pressure of a gas means, as simple as that. So don't overthink what Dalton's law is saying. It's just saying that the partial pressure of gases can add it up together to give you a total amount of pressure in the whatever it is, a container, whether if there is a container. If not, then it is atmospheric pressure. Okay. Second, how much pressure is exerted will affect how much of that gas will be able to go in and out of a solution. This is defined by another law called Henry's law. Okay, so make sure you know these two laws and the basis of what they're saying. So by Henry's law, which says that the amount of particular gas in the solution is directly proportional to the partial pressure of that gas. So it's saying that whatever partial pressure that gas is, the higher it is, the more of it will go into solution, okay? So Dalton's law has to do with the partial pressure being part of a total pressure, and Henry's law says that partial pressure is related to how much of that gas is in solution. So if the partial pressure of a gas increases, more of it will go into solution, okay, more. And if a partial pressure of a gas decreases, then more of it will come out of solution, okay? And for gas coming out of solution is not solidifying, not precipitation. That's not solids, when we're talking about coming out of solution for a gas, it means it's escaping into the atmosphere or the air around it. Now, to illustrate this point, you can think about the gas that's inside a soda can, like your book suggested here doing. In a very confined, tight space of a soda can, for example, the amount of carbon dioxide inside the can is under high pressure because of the small amount of volume. So some of that gas is forced into solution because there's no space to escape into the air. So this higher partial pressure of carbon dioxide inside the can means that more of that gas will be going into solution, the fluid portion of the soda. Okay, so that pretty much says in this confined space volume, we're limited in that by the space inside, which means the partial pressure of CO2 inside the soda can will be very high. And by Henry's law, the higher the partial pressure of that particular gas, more of it will go into solution. Now, if we were to open the can of soda, we will relieve that pressure inside the can, and because now that there's all this volume in the whole atmosphere around the can, so all that gas will escape into the atmosphere from inside of the can, and hence the partial pressure of carbon dioxide decreases inside the can, which will then result in less of that gas will remain in solution. This is why when we first open the soda can and pour it out in a glass, for example, we see all these little bubbles fizzing in there, because those are the carbon dioxide gas that was in solution, and now they're all escaping into the atmosphere now that we've opened the soda can. And this also explains why you leaving that glass of soda out long enough will cause the soda to become flat. Okay, well, when we say that, the soda has become flat, it's not fizzy anymore, is because all that gas within the liquid has now escaped into the atmosphere instead. So if we apply these two laws we're doing, okay, we're talking about into the respiratory system, Dalton's law is what allows us to measure the amount of oxygen and carbon dioxide by partial pressures. Henry's law is what allows us to say that the higher the partial pressure of oxygen or carbon dioxide that we have, the more of it will go into solution of the plasma within our blood. More gases going into solution means more will be picked up by our hemoglobin within our red blood cells or erythrocytes. So that's the only thing that these two laws are saying. It's setting it up, setting up the basis or foundation why we can put a value into how much oxygen or how much carbon dioxide we have at any given point in the body, and why diffusion of the gas across the alveoli epithelium or the blood-air barrier works, is because the higher partial pressure there is, more of it will go into solution. Okay, so that's pretty much what these two figure is just trying to illustrate, the fact that once we have relieved the pressure within the soda can, okay, partial pressure of CO2 will decrease because a lot of it has now escaped into the atmosphere on the outside. Okay, all right. So now, based on those basic concepts of Henry's law and Dalton's law, we can now look at the different partial pressures of oxygen versus carbon dioxide that makes external respiration and internal respiration possible. Now, remember in the beginning of the lecture, I talked about that there is no pump or anything to tell the oxygen or carbon dioxide which way to go, in what direction, and in what location. How does oxygen knows to flow into blood within the lungs, and how does oxygen know to flow into cells when they arrive in peripheral tissues? It's kind of like what we were asking with the capillary exchange. How does things just know where to go? Well, all of this is driven by differences in partial pressures of the two gases, kind of like osmosis. So with external respiration, we mentioned that what is defined as gas exchange is what happens between the alveoli and the capillaries. So that's what defines as external respiration. So blood arriving from the pulmonary arteries should be deoxygenated. So we're talking about right here, okay? Blood is entering via the pulmonary artery. So I'm going to write that down. It's coming from the pulmonary artery, which, like I said, it should be deoxygenated blood because they have just came back from venous circulation via the vena cava into the right atrium and went into the right ventricle through the pulmonary trunk to get to the lungs. Now, when we say deoxygenated blood, that doesn't mean those blood do not have any oxygen in there at all. Okay, there's pretty much no time at one point where red blood cells floating in your body is completely 100% deoxygenated. It's just a way to say that represent blood as having dropped off their oxygen and they got to go back to the heart and the lungs to pick up more. So it's just that they have fewer amount of oxygen in there. That's what we mean by deoxygenated blood. Okay, so just to make sure and clarify what deoxygenated mean. So the partial pressure of oxygen coming back from the systemic circuit is lower. Okay, so oxygen, partial pressure of oxygen coming back in should be about 40 millicurie. Now again, these numbers are relative and can differ a bit between textbooks and video resources, but the overall pattern of which is higher or lower should be the same across the board. For us, we will remember the number given to us by the textbook we use in our class. So remember that PO2, partial pressure of oxygen, is about 40 millicurie coming in from the pulmonary artery into the lungs. And because the blood just came back from the systemic circuit, the amount of carbon dioxide they have would then be higher because they have just picked up carbon dioxide from the peripheral tissue. So the partial pressure of carbon dioxide is about 45 millicurie. Okay, so that's why here it says PCO2 is about 45 millicurie. Okay, so that is the two partial pressure of oxygen versus carbon dioxide coming in from pulmonary artery. Now, when blood arrives at the lung capillary next to the alveoli, so the red blood cell, okay, coming in, and now let's stop it there, and we're going to look at it here now. Now it's directly next to the alveoli. Okay, so these gases then will diffuse across the blood-air barrier, which is this one right here, okay, blood-air barrier between the alveoli and the capillaries according to their partial pressure gradient. Now, just like solids in a solution, gas will always flow in the direction from a higher partial pressure value to a lower partial pressure value. So within the alveoli, the partial pressure of oxygen is about 100 millicurie because you just breathe in fresh air through the lungs. So there should be a lot of oxygen within the lungs. As denoted by here, PCO2 is 100 within the alveoli. While the partial pressure of carbon dioxide should be lower because we have breathed out. Okay, that's what the whole purpose of exhalation is for, is to get rid of carbon dioxide. So the partial pressure of carbon dioxide is about 40 millicurie because you breathe out carbon dioxide. So there shouldn't be a lot of that gas inside the lungs. Okay, so PCO2 is 40 within the alveoli. So because of this difference in partial pressure, okay, of the two gases, oxygen will flow from the alveoli into the blood. Okay, that's why you have this arrow here saying oxygen will flow in from the alveoli to the blood, because partial pressure of oxygen is 100 in the alveoli and it is 40 within the artery, okay, or capillary, okay, capillary coming in surrounding the lungs. Okay, so the 100 will allow the oxygen to travel in the direction towards the blood until they reach the same partial pressure as the alveoli. Carbon dioxide will be the same thing, but it is an opposite direction, because carbon dioxide is the numeric value for partial pressure is 45, within the alveolus is 40. So this being higher in the blood will allow the carbon dioxide to flow into the alveoli. Okay, so the carbon dioxide will then flow out of the blood into the alveoli of the lung capillaries, and then they will then go out into the atmosphere when we have exhalation. Okay, so that's how the partial pressure of carbon dioxide stays low within the alveoli, okay, until they have reached the same partial pressure. So blood coming out of the lung capillaries overall, as a summary, should have partial pressure of oxygen at 100 millicurie and partial pressure of carbon dioxide at 40 millicurie. Okay, so now it has just picked up oxygen and dropped off its carbon dioxide. Okay, so now you should understand why oxygen knows to come in from alveoli and why carbon dioxide knows to go in the direction towards the alveoli from the blood during external respiration. Now, but because gas exchange only occurs at the alveoli and the conducting passageways always carry very little oxygen, the partial pressure of oxygen actually drops to 95 millicurie as soon as it enters the pulmonary veins, going back to the left side of the heart, the left atrium, the left ventricle. Okay, so that's why here you see partial pressure of oxygen at 95 and CO2 is still the same. Okay, so then blood will travel from the pulmonary vein back into the heart's left atrium and left ventricle, followed by the aorta to the rest of the systemic circuit. Okay, so here, going this way out is representing the pulmonary vein and then the rest of the heart. Okay, so when blood reaches those peripheral tissue, okay, so these right here is peripheral tissue. Okay, there will be gas exchange between those cells and the blood coming through the systemic capillaries, called internal respiration. Okay, internal respiration. And what happens is normal interstitial fluid, okay, meaning those fluid, remember by now you should understand and remember what interstitial fluid mean. It's not what's in the blood, but what's in the tissue here, okay, between the cells. So the partial pressure of oxygen should be low because they have just used up their oxygen for cellular respiration to make ATP to power whatever they need to do inside the cell. So okay, I want to make sure that's not covered. So the partial pressure of oxygen is about 40 millicurie within the tissue, whereas the partial pressure of oxygen coming in to the peripheral tissue around them, the capillary capillary bed that surrounds them, has blood coming in with partial pressure of oxygen being 95. So then again, partial pressures is different, and gases will travel in the direction from higher pressure to lower pressure. So that's why oxygen will flow out of the blood into the tissues. Now, inactive peripheral tissue normally have a partial pressure of carbon dioxide of about 45 millicurie because, like I just said, tissues are doing cellular respiration, and a byproduct of cellular respiration is carbon dioxide. So they generate all these carbon dioxide. So that's why their carbon dioxide partial pressure should be a little higher, which is 45 millicurie, while the partial pressure of carbon dioxide just coming fresh into the capillary network is low, and it's about 40 millicurie. Okay, and because you have higher partial pressure of carbon dioxide within the tissues, the carbon dioxide will then flow out of the tissue into the blood to be picked up by either the plasma or the hemoglobin within the red blood cells. Okay, so oxygen flows out, carbon dioxide goes in according to these differences in partial pressure. And by the time now that they're going to enter back into the venous circulation, they should be equalized, where your partial pressure of oxygen is now down to 40 again, because you have just dumped off oxygen to the tissues. And then the carbon dioxide partial pressure will be back to 45 because you have just picked up carbon dioxide from the tissues. Okay, drop off oxygen, picked up carbon dioxide. So now you're going to come back into venous circulation, and then you're going to travel all the way back up here again and repeat the whole cycle all over again. Okay, so it's pretty simple going through external respiration and internal respiration. What are the partial pressure values? Why oxygen or carbon dioxide is traveling in the direction that they're doing? And then what happens during internal respiration? And then the whole process starts all over again and again, and go in cycles as blood is dropping off oxygen and picking up carbon dioxide, or vice versa, depending what location the blood is traveling to. And why those gases know where to go is all based on partial pressure values. Okay, all right. So even though technically speaking, gases like oxygen and carbon dioxide can dissolve into solution that we were talking about, but only limited amount of those gases actually go into solution due to their solubility level. Okay, so this is something you'll learn in chemistry, what the solubility of gases. So I'm not going to go into it into detail here. It's just saying that, just because there's a lot of gas around, not 100% of that gas will go into solution. So of course, we wouldn't need, if everything was 100%, blood, oxygen will just all by gas go into the plasma, and they can travel perfectly fine within the plasma, then we don't need the existence of red blood cells in our blood. The whole purpose of having erythrocytes in our blood is so the hemoglobin in the erythrocytes can serve as a better vehicle for oxygen and carbon dioxide to transport those gases than plasma alone. So when oxygen or carbon dioxide is high within the blood plasma, the red blood cells will remove the excess molecules by picking them up, letting them bind to their heme group. Okay, that's the whole purpose of those red blood cells we talked about in the blood chapter. And when carbon dioxide or oxygen levels are low in the blood plasma, the red blood cells will then release their stored reserves. Okay? And we have already talked about that when oxygen is bound hemoglobin, we refer to them as oxyhemoglobin. And we emphasize that the binding interaction should be weak so that hemoglobin can drop off oxygen and easily pick them up and easily drop them off wherever they're needed. Okay, so this process should be weak and reversible. Okay, meaning they can be picked up and they can be dropped off to allow oxygen to be delivered where they're needed and be picked up wherever there's a lot of oxygen available. Okay, so there are 4 pockets of oxygen molecules that we talked about in one hemoglobin, due to the fact that they have 4 heme units on each hemoglobin. So how much or how many of those heme unit is saturated or bound to oxygen is referred to as hemoglobin saturation levels. Okay, so if all 4 heme units are bound, it is equivalent to 100% hemoglobin saturation. So the most important factor affecting hemoglobin saturation is the partial pressure of oxygen within blood. If the partial pressure of oxygen increases within the blood, then hemoglobin will bind more to oxygen. If partial pressure of oxygen decreases in the blood, then hemoglobin will release oxygen. Okay? And so this curve here shows a nonlinear relationship because the shape of hemoglobin actually changes slightly each time it binds to an extra oxygen molecule. Which means that the binding of one oxygen molecule to one of those heme group will enhance the binding of the next oxygen molecule, meaning, having oxygen already bound to the hemoglobin and, sort of makes the hemoglobin itself more attractive to binding more, or making them having a higher affinity for more oxygen molecules to bind. And that's why you see this saturation curve here as a curve and not a linear relationship. Okay, because there's a reason for that I'll talk about next. Okay, so this being a non-linear relationship is a good thing, okay, because it allows us to be able to have adequate amount of oxygen at a wide range of different partial pressure of oxygen in the environment, or else we will, technically speaking, suffocate whenever we go up to the top of those high mountains, because those areas of higher altitudes actually have lower levels of oxygen available. And if it wasn't for this saturation curve being non-linear like this, at a certain level of partial pressure of oxygen, the saturation level will be a lot lower, and that can make us, have a severe impact on our ability to deliver oxygen to our tissues when we go to different altitudes all over the world. Okay, so for example, if we follow the curve, even at partial pressure of 60 millicurie of oxygen level, okay, which is represented by this number here, hemoglobin, okay, 60 millicurie is actually a lot lower than normal levels of oxygen. So our hemoglobin are still at about 90% saturation, even at a much lower partial pressure of oxygen level, due to this non-linear curve of the saturation of oxygen. This also allows us to perform different levels of activity and not completely run out of oxygen and become desaturated completely, because with inactive tissue, hemoglobin saturation goes from about 97% saturation, okay, at, for example, partial pressure of 95 millicurie that we were talking about, to about 40 millicurie of partial oxygen that we just talked about. So that only went from 97 saturation to about 75% saturation. So while we're just sitting there doing nothing, your hemoglobin are still, even after it has dumped off its oxygen to your peripheral tissue, there's still a good 75% saturation, which means we can still do a little bit more than just doing nothing, okay? And hence, in active active tissue, the hemoglobin saturation can go from your 97% due to this partial pressure of oxygen to down to partial pressure of oxygen to 15 or 20 millicurie, which results in about 20% saturation because of the now high oxygen demand by your, for example, your skeletal muscles to burn more ATP to power whatever active exercise that you're doing. Okay. So because of this curve, it allows us to survive at different altitudes and also always have enough oxygen reservoir ready in our hemoglobin to be active and exercise. Okay, use them for activating our skeletal muscles. Okay. All right, so there are two other factors that can affect hemoglobin saturation level: pH level and temperature. Okay, so how pH level can affect hemoglobin saturation level is referred to as the Bohr effect. Okay, Bohr effect. So notice in this chapter that we have a lot of different names that's not anatomically related. Okay, so now it's starting to be like chemistry or physics, where there's these laws and different names based on whoever discovered that particular effect or whoever discovered that law. So for me, I have a hard time remembering these things. So I highly suggest for you, if I was the student as well, to have a list of definitions down on your own notes so you are clear what's what. For example, be sure to write down what's Dalton's law, what's Boyle's law, what's Henry's law, what's Bohr effect. Okay, so that you can consistently review these different terminologies and know what they're referring to. Okay. Sometimes it may not be straight definition of these law that's being asked on the exam. It could be an application of these law that's being asked on the exam. And you may know the definition, but you don't know the application. So make sure you know the whole story of each terminology that's within these chapters. Okay? So the Bohr effect tells us that when pH level decreases, meaning we're getting more acidic conditions, the shape of the hemoglobin will change so that they will release more oxygen reserves more readily. Okay, so the whole saturation curve here is decreased, okay, when pH goes down to about 7.2. Now, of course, the opposite happens if pH levels was to go up to be more alkaline, around 7.6. The whole saturation curve is increased. Okay, so why is this the case? So you may wonder, why would our body's pH level change? What factor is it that is changing our blood pH? Well, a big contributor that directly affects our blood pH is the amount of CO2 that is present. Why? Well, it has to do with the reaction carbon dioxide has with water right here. Okay, when CO2 diffuses into the blood, it goes into your red blood cells where an enzyme called carbonic anhydrase turns carbon dioxide into an acid, okay, carbonic acid. And because carbonic acid is a weak acid, it will dissociate into its components partially. That's why there's these equilibrium arrows here into bicarbonate ion and hydrogen ion. Okay, now this reaction also happens with chemicals just on their own. Okay, and that's why in the respiratory physiology lab, one of the activity is for you to blow into water. Okay, and that water contains a pH indicator, and as you're blowing in to the water, you will see the pH change. Is because on its own, spontaneously, carbon dioxide will combine with water to generate carbonic acid, which will then dissociate into bicarbonate ion and hydrogen ion. But it's just that in blood, it's a lot more efficient with that enzyme carbonic anhydrase in there, okay, and makes the reaction of forming carbonic acid even faster. Now, because of this dissociation of hydrogen ions within the solution, this is why the pH level will go down. Okay, remember pH is defined by how much hydrogen ions is within the solution, and hence because carbon dioxide is forming carbonic acid, thereby releasing hydrogen ions into the solution, that is why the pH level of blood can technically decrease or become more acidic. All right, so now I highly suggest for you to know this reaction now, because it's going to come back again when we get to the fluid electrolyte chapter, where we also talk about acid and base balance in the body. And you have to understand which way the reaction go under different circumstances. Does the reaction go this way to form more acid, or does the reaction go this way to form more carbon dioxide for us to breathe out? So this is a key reaction you have to know, okay? Make sure you remember this. Carbon dioxide with water makes carbonic acid, which will dissociate into bicarbonate and hydrogen ions. We're going to come back to this, and you have to know this reaction back and forth, because that's the whole idea of what the fluid electrolyte and acid-base chapter is all about, okay? What does your lungs do, or what does your kidney do if your body was to increase in the amount of hydrogen ions, or if your lungs was saturated with too much levels of carbon dioxide? What does your body do to bring things back to homeostasis? Okay. So it's better to know this reaction now than having to understand it later. Okay. Make sure you understand this reaction now. Okay. All right. Now, like I said, because the reaction ends up releasing hydrogen ions at the end of the reaction, it ends up acidifying the solution, lowering the pH value. So, when we have elevated levels of carbon dioxide, the rate of carbonic acid formation will increase, which means a lot more hydrogen ions is being made and dissociated from carbonic acid, and they would diffuse out of your red blood cells, lowering your blood pH, which then will trigger your red blood cells or hemoglobin specifically to release more oxygen. And this makes sense because there's more carbon dioxide around, so let's drop off those oxygen so we can bind more to carbon dioxide and deliver them to the lungs so we can exhale more of that carbon dioxide back into the air. Okay? Now, this effect, the next effect with hemoglobin saturation level is temperature. Now, with temperature effect at a given partial pressure of carbon dioxide, hemoglobin will release more oxygen if blood temperature increases, and as temperature decreases, hemoglobins will hold on to oxygen more tightly. So usually, remember, our blood temperature is about 38 degrees Celsius. So if it was to heat up to 43 degrees Celsius, the saturation curve is decreased because it's now warmer or hotter. And then at colder temperature, either 20 or 10 degrees, then your saturation level of oxygen is a lot more because it's cold, so they hang on to oxygen more. So at higher temperature, the hemoglobin saturation level goes down. Okay, now this effect is only significant if we're talking about active skeletal muscles. Okay, that's what heats up our body. Okay, where a large amount of heat is generated by our active skeletal muscles, and it warms up the blood that flows through it. Okay, so that is most this heat temperature effect is when it's most significant, is when you are exercising, for example, doing strenuous exercise. It really heats up your blood. So then they will release more oxygen, and it makes sense because if you're activating and moving your skeletal muscles during strenuous exercises, more oxygen is necessary to supply the muscle fibers to conduct their cellular respiration in production of ATP. So more oxygen will be needed to be released. Okay. And with that in mind, we can define, we just talked about saturation of oxygen. Well, what about carbon dioxide? Well, with oxygen, remember there are two ways to transport oxygen. Either oxygen itself diffusing into the plasma itself, or oxygen is bound to hemoglobin via oxyhemoglobin. Well, what about carbon dioxide? How are carbon dioxide transported? Well, two of the ways is still the same thing. Okay, carbon dioxide, some of it will go into solution, and some of it will be bound to hemoglobin. But there's a third way that carbon dioxide, in a sense, can be indirectly transported. So about 70% of the carbon dioxide that's absorbed by your blood is transported as bicarbonate ions, which is the reason why I said you have to know the chemical reaction of carbon dioxide and water very well. Because at this point, you'll be like, wait a minute, where did bicarbonate ion come from? Well, bicarbonate ion, in a sense, is storing and transporting that carbon dioxide because CO2 plus water gives you carbonic acid, which then dissociates into bicarbonate ion right here and hydrogen ions. Okay? So from this reaction we talked about earlier, the hydrogen ions that's generated will bind to hemoglobin. Okay? So this hydrogen ions will be bound to hemoglobin this way, okay? Temporarily anyway, before they go into plasma and affect the blood's pH. Okay, so they will come out, okay, but they will be stored temporarily by your hemoglobin. Bicarbonate ions actually serve as a good buffer for our blood because it can bind to extra hydrogen ions to remove them from solution. So red blood cells tend to want to exchange. So after this reaction, you have both of these constituents inside your red blood cells. Hydrogen ions will bind to hemoglobin. What about bicarbonate ion? Well, bicarbonate ions won't stay bound to the red blood cells. Some of them will actually be exchanged with chloride ions to go into the blood plasma. Okay, so HCO3 bicarbonate ions will be floating around within the plasma as well, because, like I said, they serve as a good buffer. And this buffering capacity of bicarbonate ions is something we will talk about in the fluid electrolyte acid-base chapter. So make sure this is why we're kind of introducing it here, so that by the time we're there, it should be a review, okay? So red blood cells tend to exchange bicarbonate ions, like I was saying, with chloride ions here as a counter ion transport, okay? Because one ion goes in, one ion goes out, okay? And they are both negative ion, okay? So we call this a counter transport, if you remember from what we talked about, okay? Co-transport, counter transport, etc. So this counter transport is called chloride shift. Okay, so the use of this bicarbonate ion, we will discuss more in the urinary and fluid electrolyte chapter when we get there. Okay, so we're just going to say that bicarbonate ions are bound to hemoglobin, and some of it will be dissociated and exchanged for chloride ion into the plasma liquid. Okay. Now, a second way carbon dioxide is transported, like I was talking about, is by binding to hemoglobin itself as carbaminohemoglobin that we already talked about back from the blood chapter. About 23% of your CO2 level is carried by this method. And the last way of carbon dioxide transport is by diffusing into the plasma in solution, okay? And only 7% of that carbon dioxide is transported this way. So this diagram here serves as an excellent summary for what is happening in external respiration and internal respiration, and which gas gets transported via which way, and it also lists the partial pressure of gases at different locations of the body. So right here is talking about representing what's happening in the alveolar, and then the capillary that's right next to the alveoli. So this portion of the picture here is depicting external respiration. Okay? Whereas now when the blood travels to your peripheral cells, and these are the capillaries, systemic capillaries that travels into your peripheral tissues as capillary network, this here, okay, both of this here, okay, so that's how we're separating this. This here is then representing internal respiration. Okay, internal respiration. Now, in external respiration, it tells you that oxygen is being picked up because your alveoli partial pressure of oxygen is 100 and CO2 is 40. Okay, so oxygen is being picked up from your alveoli, and oxygen is bound to hemoglobin within your red blood cells, or it's diffused into the plasma. Okay, so either by diffusion into the solution itself or bound by hemoglobin as oxyhemoglobin. So then this blood will then travel towards your systemic capillaries into those that are close by your cells within your peripheral tissue. So now here, because the partial pressure of oxygen within the tissue is about 40. Partial pressure of CO2 is about 45 due to the reason we already discussed, okay? This being higher in oxygen value, remember by the time it reached here, your partial pressure of oxygen has decreased to about 95 due to the fact that you're no longer in the alveoli, and you lose a little bit of oxygen that way. And carbon dioxide is about 40, so you dump off oxygen. Hemoglobin will release as oxygen level. Okay, oxygen from the plasma will also go into your tissues, interstitial fluid. Okay, so oxygen is being dumped off from the red blood cell onto your peripheral tissue. So now what happens with carbon dioxide? Carbon dioxide is higher in peripheral tissue. So now carbon dioxide can travel back into the blood via 3 ways. One of the way was diffusion straight into the liquid plasma itself. Second way is that it will bind to hemoglobin as carbaminohemoglobin. And third way that we just discussed is by bicarbonate ions, okay? Because water will combine with CO2 to generate carbonic acid, which will then dissociate into bicarbonate ion and hydrogen ions. Hydrogen ions will bind with hemoglobin temporarily as this right here, which will eventually will be released back into the plasma or made back into CO2, either way. Okay, bicarbonate ion can also exchange with chloride ions as a counter transport in the way via chloride shift. Okay, so now after the red blood cell is packed with carbon dioxide, it now travels back via your venous circulation back into your heart and your lungs to pick up oxygen or dump off carbon dioxide. So Those that were in the plasma, of course, will diffuse straight into the alveoli that way. Those that were bound to hemoglobin will become detached. Hemoglobin is released back. CO2 then goes back into the alveoli. And whatever remaining, either hydrogen ions or bicarbonate ions, they can go back into carbonic acid, form more carbon dioxide to be released into the lungs. So this reaction here becomes a critical point as to how much carbon dioxide we have in peripheral blood. And so we can try to get rid of that extra carbon dioxide by forming more bicarbonate ions and carbonic acid to be breathed out through your lungs. Okay. At this point, you may not understand this. You're like, okay, why are they forming bicarbonate ions and they're reforming that acid back? They put it here to help you understand what we're going to go over in the acid-base chapter as a way of homeostasis, okay? It sounds counterproductive right now, okay, that you're dissociating carbon dioxide and forming them back here, okay, but there is a reason for that, okay? So just understand it as it is now, and it will become clear when you get to the acid-base chapter why your blood is doing this, okay? So just understanding as it is for now. Okay. All right. So that's why this picture here pretty much summarizes the whole physiology of gas exchange. Okay. For external and internal respiration. All right. And just as we had talked about the nervous control of cardiovascular system, we have the same control for respiratory system. Again, the brain has involuntary respiratory center. Now, we talked about how there's cardio centers, okay, found a cardiovascular center named cardioacceleratory and cardioinhibitory. So, of course, there's then the respiratory center within the brain, specifically within the medulla oblongata and the pons. And they can adjust our respiratory rhythm by regulating activities of our respiratory muscles to either increase or decrease the frequency of how often we are breathing. So how our so-called respiratory rate. Are we doing like this, breathing very fast, or are we doing very slowly? Okay, so, and they can also affect the depth of pulmonary ventilation. How deep are you breathing? Are you breathing in really strongly, or are you just doing quiet breathing? Okay, forced breathing versus quiet breathing that we talked about. Okay. Of course, some of this we can voluntarily try to do too, but your body will automatically trigger these differences in respiratory rate and the depth of your respiration based on need as well. So that's why while you're running on the treadmill, working out, you can't tell your body, hey, can I just do quiet breathing right now? You can't. You're automatically shunted to do forced breathing when you're doing exercise, heavy, strenuous exercise, because that's what your body needs to do at the moment. And we have, your brain already has involuntary control over that. So how fast we breathe and how deep we breathe. And since we're talking about levels of oxygen and carbon dioxide here with the respiratory system, we are then dealing with chemoreceptors and baroreceptors. Remember, we talked about how chemoreceptors can sense how much CO2 is what level or partial pressure level of carbon dioxide we have within the body. So if there is an increase in partial pressure of carbon dioxide in our arterial blood, that is referred to hypercapnia. Okay, so capnia usually has to do with the word that means how much levels of carbon dioxide we have. Okay, so hypercapnia means too much carbon dioxide level. So When we have too much carbon dioxide, our chemoreceptors within carotid bodies, which is located right next to your carotid sinus within that particular artery, and there is also aortic bodies near the aortic arch of the aorta, they will be stimulated when you have an increase in carbon dioxide level, and that will increase then your rate of and depth of respiration. Because think about it, there's too much CO2 in your body right now. They're all stuck in there. Okay, so how are you going to get rid of them? You're going to breathe faster. Okay, that way you can try to get rid of that carbon dioxide by breathing faster and breathing deeper. Okay, so you're going to increase your frequency and you're going to increase your tidal volume to be higher so you can get rid of all those extra CO2 around. So that will lead to faster diffusion of carbon dioxide out of your alveolar capillaries. Okay? So on the other hand, when you have abnormally low levels of partial pressure of carbon dioxide, okay, as you have guessed, if too much is called hypercapnia, too low is then called hypocapnia. Okay, now normally speaking, we never go into too low levels of CO2, only under cases of abnormal situation or in the case of hyperventilation. Whether we're trying to do this voluntarily or someone can go into hyperventilation mode when they're in, for example, in a panic attack. If they have anxiety issues, they can go into hyperventilation involuntarily as well. So hyperventilation is when the rate and depth of respiration is so high that you're breathing in too much oxygen and releasing too much carbon dioxide. Okay, this will then lead to an inhibition of your chemoreceptors, which will then trigger for respiratory rate to fall and decrease back to homeostasis. So even if you tried hyperventilating right now, okay, not that I'm asking you to try, but we do actually do this exercise in lab, is we will ask students to hyperventilate and then for about I think a minute, and then you will, breathe into a bag to see how long you can hold your breath. Okay, you will actually notice that you can hold your breath a little longer because you've been breathing in a lot of oxygen. But the thing is, we ask students to make sure they're sitting down, because when you're hyperventilating, you're breathing in a lot of oxygen. That's nice, but then you're also breathing out too much carbon dioxide, which can cause you to feel a little bit dizzy. Okay, so for me, when I try to even do maybe 10 hyperventilation, a couple seconds of hyperventilation, my brain already starts to feel a little queasy. So I don't try to do this. But that's what happens, okay? And it makes sense then after hyperventilation, because you've been breathing so fast, in order to bring your gas levels back to normal levels, you're going to decrease your respiration rate and decrease how deep you're breathing, so then you can breathe normally again and be able to calm down. Okay, and that's why when someone is hyperventilating involuntarily, let's say they're in their panic attack and they have anxiety and they're breathing, hyperventilating out of their control, and that's why then you give them a paper bag back then. You've all heard of the story. Let them breathe into a paper bag and they will settle down. Because when you're breathing into the paper bag, you're breathing in back your carbon dioxide that you're breathing out, okay? In a sense, you are allowing that carbon dioxide gas level to be built back up again in the body, okay? And then hence that will calm your body back down, okay? All right, and baroreceptor reflexes has to do with blood pressure, as we have talked about in the blood vessel chapter. And when blood pressure falls, for example, your respiratory rate will increase along with other things that affect the cardiac output to bring blood pressure back up to homeostasis. If you revisit that homeostasis chart from the last chapter on chapter 21, blood vessel and blood pressure, you will notice that there is a respiratory rate factor in that homeostasis chart as well. And when blood pressure gets too high, respiratory rate will decrease along with other cardiovascular effects to bring down blood pressure back to normal levels. Again, if you forgot about this, go back and revisit those homeostasis chart from chapter 21 on what happens if blood pressure gets too high and what happens with blood pressure gets too low. In addition to cardiovascular and vasomotor centers, it also includes your respiratory rate there. Okay, so now this is the homeostasis chart for regulation of carbon dioxide level, whether if you're in hypercapnia and hypocapnia, and what happens to your chemoreceptor under these two different conditions, what is stimulated, what is inhibited, what is as a result happens to bring your carbon dioxide levels back down to homeostasis or bring your carbon dioxide levels back up to homeostasis. Okay, so see how I said I wasn't kidding when I said every chapter has multiple of these homeostasis chart last semester when I was going over some of the stuff in 2401. Okay, so other than chemo and baroreceptor reflexes, we're almost done here, so bear with us. Okay, so bear with me. There are also other reflexes that exist for the respiratory system. Okay, one of it being called the Herring-Breuer reflex. Okay, Herring-Breuer reflex. Again, this reflex has to do with how much we can inflate or deflate our lungs. And again, I will add this to your list of terms to remember along with all those other law names. This particular reflex, again, is named after the two guys that discovered this reflex. And, I personally is not a fan of history. And with, those names involved with history, I always have the hardest time memorizing them. So, with anatomical terms, at least we can have some clues and meaning to their names. I can relate to those very easily. But with these terms that come from a person's name, unfortunately for me, it's just pure memorization. It's hard for me to relate to them. So if I was a student, I would definitely make a separate list of these terms so I can review them very often and, as a condensed list on the side so I can consistently review what these terms means and what they're referring to. So then comes application of these particular terms or laws or reflexes, then I know exactly what they are. So in order to apply them, if you don't know what they are, you can't apply them to a question. Okay, so this Herring-Breuer reflex, if I was to put it in common crude language, is pretty much saying that we can never inhale so much air to the point where our lungs will explode, or we will never exhale too much air that our lungs will completely collapse. Okay, so that's the crude way of pretty much putting this Herring-Breuer reflex into summary. But it actually is broken down into two separate reflexes, the inflation reflex and deflation reflex. So if I want to be more technical and make it sound biologically correct, inflammation reflex says that if we breathe in air as forcibly as much as we can, it will stimulate those stretch receptors within the smooth muscles around those bronchioles, and it will eventually inhibit inhalation and activate exhalation, okay, when lung volume goes up. Pretty much saying you can try as much as you can to breathe in to a certain point, and then you're like, wait, I can't breathe in anymore, and then you have to exhale. Okay, well, that's because of this inflation reflex. Okay, you can't say I'm gonna be like a Superman and try to inhale and expand my lungs to the size of a barrel. Okay, that can't happen due to presence of this particular reflex. You will automatically say you can't go anymore and you have to exhale those air gas out. Okay, so the deflection reflex says the opposite. We can try to exhale as much as we can forcibly, but there will be receptors located in the alveolar wall that senses a drop in volume of the lungs and automatically trigger inhibition of exhalation. Okay, and so receptors within the alveoli wall and trigger inhibition of exhalation and stimulate inhalation instead. Okay, so you will inhibit exhalation and stimulate inhalation. Okay, which is saying that no matter how hard we try, we will never be able to deflate our lungs completely to be having completely no air inside. We can try to blow out as much as we want. Ooh. Well, eventually we gotta stop, okay, and say, wait, I can't anymore, okay? And then you go into your inhalation mode, okay? So, those are what Herring-Breuer reflexes is saying, and something that we can't go more than we want. All right, so there are also what's called protective reflexes as well that serve to protect our respiratory system from things that are harmful. When we inhale chemical irritants, for example, that our body doesn't like, we may trigger a sneeze or a cough reflex depending where that irritant has gotten into. For example, imagine rubbing or smelling very spicy chili peppers in your nostril. Well, many people may end up sneezing or even coughing depending how far that spice has gotten into. Both of these reflexes involve a momentary period of what's called apnea. Okay, remember I said apnea has to, nia has to do with respiration. Okay, so apnea means no respiration. Okay, so it is defined as a time where respiration is temporarily suspended, let's hope temporarily, and no breathing happens due to a closed glottis. That's what apnea means. Okay, so we go into that momentarily apnea, and then it is followed by a forceful expulsion of air that comes up from your airways to remove that irritant in form of a sneeze or a cough. So that cough reflex, for example, that I talked about. So the sudden contraction of your abdominal and internal intercostal muscles will reopen your glottis for that forceful air expulsion. Okay, and of course, please don't sneeze like this guy outwards like that in time of this COVID-19 pandemic. And even if it's not the pandemic, you shouldn't sneeze out there like that. You release a lot of little droplets like this. Okay, this is bad. Okay, but is that it is absolutely critical that you're covering your mouth when you sneeze or cough, so those droplets don't end up spreading whatever germs one have. If it's a virus, okay, we don't spread the virus everywhere, okay? So this momentarily temporary period of apnea is why when we sneeze, we're like, we kind of do that, and then ha-choo, okay? Well, that before we get to the point of sneezing is those momentary of apnea, okay? Closing up your glottis, and then you can expel that, that gas and air out of your nose, okay? All right. Laryngeal spasm then is actually triggered usually by chemical irritants or foreign objects or fluid if they have gotten into your larynx area around the glottis. Remember, the glottis doesn't like things touching it, okay, because it's not meant for solid to go down your airway. So if glottis senses anything that tries to get in there, of course, the first thing is cough reflex, and if it stays in there, it may close the airway temporarily and be due to laryngeal spasm to try to get rid of it. Whatever this chemical, that's why some chemical irritant may lead to those laryngeal spasm, or in the case of some toxic gas, the glottis may close permanently and never open again and suffocates the individual to death. And that's why that's pretty much how those toxic gas work, is those particular chemical irritate your glottis so much that the glottis just close up, okay, and suffocates the individual. All right, and the last part of the chapter, as you can kind of see the pattern with each of these chapters for the textbook, is they like to wrap up the chapter with how age is affecting the performance of that particular organ system, whether it's be from the time you're born to the time when we age. So this is a summary of what happens with our respiratory system when we are born and what happens when we get older. Now, before our first breath, when we are still a little baby inside our mother's womb, we kind of talked about this, is that our lungs are flat with absolutely no air in there. So that's why your lungs are collapsed and filled with amniotic fluid, okay? So when we are first born into the world and take our very first breath, that very first breath out of our mother's womb is what will expand our collapsed lungs to activate our pulmonary circuit and allows air to flow into our lungs. And that's why usually the medical personnel will rub the baby's back until the baby give a loud cry, so it will get the breathing going deeper for the baby, which then will allow for those powerful contraction of the diaphragm when the baby's going wah, wah, crying really strongly, and then those working those external intercostal muscles in the chest area as well to overcome the force of the surface tension within the bronchial tree and alveoli that we talked about and inflate them, okay, and causing them to now have air within the lungs. And as the lungs expand in the baby, the intrapulmonary pressure will drop, okay. Remember, when it increases in size, which means increase in volume, pressure drops. Air is pulled into the lungs, as we have discussed, and it also pulls blood into pulmonary circulation, okay. So this is what starts the pulmonary circulation running as soon as the baby is born and learn how to breathe on its own without the help of the placenta, okay. And we already discussed this from chapter 21 and cardiovascular system. Now, when we age, the lungs compliance value usually decreases due to the fact that, along with our vital capacity, due to the fact that we have deterioration of elastic tissue with the lungs, okay? That's something that will happen because things will deteriorate over time. If there is, for example, if there are any additional arthritis in the body, chest movement can also become restricted, which will limit the ability to expand your thoracic cavity along with your respiratory minute volume. Okay, you will have limited amount of volume available, which means you cannot get as much gas in when we are older. So this explains why when we are older, we may not be able to do as strenuous sports as we did when we are young. And, depending whether a person was ever a smoker, this decrease in respiratory performance, for example, as you can see in this chart, if a person is a regular smoker, that respiratory performance will decrease even faster, okay? According to what you can see in the graph here, okay, maybe sometime in their 60s, okay? It's hard to foresee what will happen in their 70s. It's just normal nature of human being, okay? We don't tend to look at what happens later on when we're in our early 20s, 30s, or 40s. We think, oh, okay, I'm smoking every day, but I'm feeling fine. Nothing's wrong with me. But according to this graph here, by statistic, it will eventually catch up on you. The deterioration of respiratory function will catch up on a smoker's lungs when they're well into their late 60s and 70s. It all depends if one wants to end up your life with emphysema or walk around with a tank of oxygen when we're old, and decide, you can decide how you want to live as a grandma or grandpa in their older age, okay? Do you want to live with a tank of oxygen or with emphysema, or do you want to stop and quit smoking sometime? Even if you were to stop at age of 45, it really decreases the rate at which your respiratory deteriorates, your respiratory system and performance deteriorates, okay? So you can live just fine without having to do all that therapy stuff, okay, or walk around with a tank of oxygen if you were to stop smoking sometime in your life, okay? And that actually includes vaping as well, okay? According to research, Vaping is actually more dangerous and has caused quite a large amount of lung damage in young individuals because companies try to sell these attractive, fruity, tasty vapes or e-cigarettes to go with vaping. Okay, so now let me talk about a little bit about vaping here, because I know some of you may be interested or have not heard of whether vaping is dangerous or not. Okay, well, these companies makes vaping sound so wonderful because it doesn't cause secondhand smoke around people around you, and it's not as dangerous as cigarette smoke. Well, that is not true. It's absolutely false. Okay, when I was at a cancer seminar last year at UT Southwestern that talks about the danger of vaping and how it has led to a dramatic increase of teens and young adults with very, very bad lung damage, okay, which shouldn't happen in young adults, okay? When you're a teenager, you are in your prime time of your life. If you're in your early 20s or middle 20s, okay, your lungs should not be deteriorating and getting damaged. And according to the CDC website, as of February 2020, there have been a total of 2,807 cases of hospitalization and deaths related to e-cigarettes and vaping due to the lung injury that it's causing within the United States. Okay, and yes, those original cases were associated with a particular chemical called vitamin E, okay, vitamin E acetate, which is now mostly removed from e-cigarettes. But you never know what else they would discover later on with more deaths coming that would result in permanent lung damage, okay? So, smoking of any form is never good for you. Vitamin E acetate, somehow it's okay when we ingest them through our digestive system, but when we inhale them into our respiratory tract is not a good idea. Okay, it does something weird with your respiratory tract and starts damaging them. Okay, so it is really sad to see, because company wants to make money, that they sell these e-cigarettes to young individuals, and about 50% of those hospitalized and death cases that I talked about were from patients under the age of 24 years old. Okay, a perfectly young adult at the prime time of their life should be doing sports, whatever fun stuff they want to do, and now they can never breathe the same way again. Okay, if they are able to live through all the lung damages that these vape e-cigarettes has caused, okay, which becomes an applicable factor to the effects of COVID-19 pandemic as well. For those with compromised lungs due to an already somewhat damaged alveoli surfaces, we talked about what the alveoli is important for, and it's supposed to be the size of a tennis court, okay? Any decrease or compromise in the alveoli is going to make it harder for you to breathe or combat diseases when it comes, for example, like COVID-19. So those individuals with damaged alveoli will have a lot harder time to recover from the virus infection, if at all. It may be fun and cool when one smokes cigarette or vapes, and then, when it becomes a habit as one age, that's what you have to live with. But it definitely does not look very cool when one is put on a ventilator, okay, on the hospital bed. So our lungs, with that tennis court size surface area with your millions of alveoli that we just talked about and discussed in this chapter, is what enables us to breathe normally, okay? So please take good care of your lungs and educate those around you as well, both young and old, okay? It's never too late to stop, okay? All right. And that's all I have for you for chapter 23 on the respiratory system. Let's go over the practice questions and we'll be done. All right, so what structure is the final part of the conducting portion of the respiratory system? Remember, we're talking about the conducting portion. So the last portion is terminal bronchioles, okay? not alveoli. The epithelium of the pharynx changes from what type of epithelium in the nasal pharynx to what type of epithelium in the oral pharynx, and why? Well, it changes from pseudociliated columnar, pseudostratified columnar epithelium to stratified squamous, and the oral pharynx is subject to abrasion of food and drink particles that's coming through your oral cavity. Why are cartilages that reinforce the trachea C-shaped? Okay, they allow room for esophageal expansion like we're talking about, so we don't go into choking episodes whenever we take a bigger bite of something. Okay, what path does air take when flowing from the glottis to the blood-air barrier? Okay, it goes from your larynx to trachea, followed by your bronchi, bronchioles, respiratory bronchioles, and then lastly your alveoli. What statement is or are true with regard to blood-air barrier? Both A and B are correct. Okay, A say that it is formed by fusion of the endothelium of your capillaries and simple squamous epithelium of the alveoli, and the diffusion of gases across this blood-air barrier occurs very rapidly. What statement below is true of the pleura? Okay, it is attached to the diaphragm and the thoracic wall. Okay, it does not mix surfactant. It does not secrete mucus and trap that particular particulate. Okay, and does not prevent friction between the esophagus and the lungs. If surfactant is not produced, what happens to alveoli due to what? Okay, it will collapse because of increase in surface tension, and instead of nice and open alveoli, you will end up with alveoli that are like this or like this, where they're stuck together in the middle. Edward breaks a rib that punctures his left lung. What is the condition called, and how will it be treated? Our infamous pneumothorax. Vacuum air from the pleural space will happen, so then that pleura that's supposed to be surrounding your lungs now compresses on your lungs because air is coming into your pleural cavity. Which of the following is not true concerning efficiency of gas exchange? The difference in partial pressure across the blood-air barrier is minimal. That is false. If it's minimal, then we're in trouble. No air, no gas exchange would happen if it's minimal. But because there are a significant amount of partial pressure differences between the alveoli and the capillary, that's how we are able to do gas exchange. If you have maximally exhaled all the air you can, which represents your ERV, what is the amount of you can now maximally inhale? Okay, so remember you have your tidal volume, okay, and then you have your inspiratory reserve volume, okay, comes back down, and then your expiratory reserve volume, okay, and then you come back up, okay. So when you are at this point, what is the maximum amount of volume you can now maximally inhale? What does this represent? Your vital capacity, okay. So IRV, ERV. Again, I'm a very visual person, so it's a good idea to know the gist of how that graph looks like very quickly, so you can know where the different volumes are associated with when we think about the total lung capacity and what volumes attributes to what. Okay, to me, I memorize diagrams a lot easier than a bunch of words. Okay, so that's why I always ask you guys, have a piece of paper when I'm lecturing so you can draw diagrams, write them down in your own in the own way that you understand it best. Okay, why is alveolar ventilation more important than the respiratory minute volume? Okay, alveolar ventilation volume, because that determines the rate of actual oxygen that is able to reach all the way down to the alveoli, which is what's critical here if we think about gas exchange. Okay. Now remember with AMP2, it is application of concepts. So it's not enough to just know definition. That's just a minimal requirement, is to know definitions. But you have to know what is the story behind that particular word. For instance, here you have to know what alveolar ventilation or volume means in order to know how to apply it in this particular question. Because I know, well, alveolar ventilation is something that is measuring how much oxygen actually get to the alveoli, okay? And that determines the efficiency of your lungs, all right? What is the functional relationship between hemoglobin and pH, which is the Bohr effect we were talking about? When pH drops, your hemoglobin saturation also drops. Which gas law states that at a given temperature, the amount of particular gas in solution, particular is proportional to the partial pressure of gas. Now, you don't have to write down the whole definition when you're trying to memorize these laws, okay? We talked about how Boyle's law has to do with P equals 1 over V. That's all you have to know. And you already know that pressure has to do with volume for Boyle's law. Dalton's law has to do with the partial pressure. So I would write partial pressure of CO2 plus partial pressure of O2, for example, equals your total pressure, okay? Maybe something like that. So it's not a whole paragraph of stuff that I have to memorize. And Henry's law is then the one that has to do with solution and partial pressure of CO2, for example. Okay? So that's all I have to write for pretty much, these laws that I can, by the time, by looking at this, I already know the gist of what that law is referring to. Okay? Bohr effect, pH. To hemoglobin, okay, saturation level O2. All right, so that's how you can easily narrow down what you have to remember for exam. Okay, what does Boyle's law state concerning the relationship between pressure and volume? Both B and C are correct, which is this formula right here, and it says that if you increase the volume of a gas, the pressure will decrease. Which of the following contributes most to the expiration of carbon dioxide? Formation of bicarbonate ion, because 70% of it is transported as bicarbonate ion. Okay, and that's all I have for you. The other slide is something I deleted out of my original lecture because, these are just long chapters, and I try to narrow it down to what's necessary and according to the objectives that we have to learn and learn for students and teach for instructors. Okay, so this wraps up our chapter 23, and I will see you. Good luck on your lecture exam coming up.